Welcome to the six-part series called Caring for Patients with Early Alzheimer's Disease, Expanding Current Knowledge and Providing Hope for the Future. The session for today is focusing on burden of disease, quality of life impacts, and pathophysiology. My name is Dr. Mark Gronin. I'm a Senior Vice President for Behavioral Health at Miami Jewish Health, where I work also as a geriatric psychiatrist. I'm also the Chief Medical Officer for Mind Institute at Miami Jewish Health, which is a memory disorder center right here in Miami, Florida. I'm joined by my friend and colleague, Dr. Richard Isaacson, who's the director of the Alzheimer's Prevention Clinic and also an associate professor of neurology and the assistant dean for faculty development at Weill Cornell Medicine and New York Presbyterian in New York City. So, Richard, welcome to the program.
Yep, thanks for having me, Mark, and I look forward to our discussion.
Absolutely. These are just disclosures for myself as a consultant for Biogen at Eli Lilly. Dr. Isaacson does not have any disclosures. The program today is provided by the North American Center for Continuing Medical Education, an HMP company, and it's supported by an educational grant from Biogen. And today we're going to focus in this first session on two specific learning objectives. First, we'll talk about the extensive burden of disease for both patients and caregivers. And to give you a good background, we'll summarize the current knowledge on early Alzheimer's disease, specifically on its pathophysiology. So let's begin by defining dementia. And I want to emphasize a change in terminology. The current Diagnostic Manual of the American Psychiatric Association now calls this a major neurocognitive disorder, getting away from a lot of the pejorative connotations of the term dementia. It's defined as a brain disease with impairment in one or more of the following cognitive domains: complex attention, executive function, learning and memory, perceptual motor skills, language, and social cognition. And one thing I just want to call your attention to is that whereas in previous definitions we said it was based on having memory impairment and other impairments, here, although memory is typically involved with dementia, specifically with Alzheimer's disease, it doesn't have to be the only or the major component here. There can be more. So that's why it's so important that all of these domains are looked at.
Yeah, and I agree, Mark. And I remember when I was in medical school, I was taught initially that Alzheimer's was really a progressive short-term memory decline. And as they progressed through dementia where they could no longer take care of themselves, then it became a neuropsychiatric disease. And then neurologists like me and geriatric psychiatrists like you would work together. But honestly, that's not terribly all wrong, but there's a lot of, inaccuracies there because, there's dysexecutive forms of Alzheimer's. There's, visual forms of Alzheimer's. There's all sorts of different, clinical manifestations. And I think that's really key. And, when we talk about the diagnosis of dementia and using the DSM-5, there's really two phases. And when we think of dementia and Alzheimer's disease across a very large continuum where someone's normal and someone at the end is having dementia where they can no longer care for themselves. But in that middle ground, they first pass through what we call a mild neurocognitive disorder, and otherwise we often call that MCI or mild cognitive impairment. That term has been used. Definitions are a little different. Prodromal AD, meaning at risk for developing the dementia phase of Alzheimer's disease. And they have some cognitive complaints, but these complaints don't interfere with the person's independence or their activities of daily living. And it's also not attributed to something medical, that we have to, of course, work up. And then there's the major neurocognitive disorder, which, again, just like you said, the pejorative term dementia, it's a very stigmatizing term. And using the term dementia, causes anxiety. Major neurocognitive disorder is a little bit, it's more descriptive, number one, and it's also, maybe a little bit softer to hear. And this is when someone is really having cognitive and other, troubles, but they now have an impact on their independence in daily life.
This is a really good general distinction that you've outlined. And a lot of people get confused with the terms major neurocognitive disorder, dementia, and then something like Alzheimer's disease. And so it's important that we point out that there are different types of neurocognitive disorders or dementia. And so if you have a diagnosis, ideally we'd like to know what type is it to the best extent possible. And through this series, we're going to talk about how we try to figure that out. But as you can see from the slide, Alzheimer's disease by far is the most common form of a neurocognitive disorder, representing roughly 60 to 70% of cases, followed by vascular dementia, either cortical or subcortical forms, then dementia with Lewy bodies. Those are the most common types. And sometimes you can have mixtures of the two as well. It's not always just one single type. Parkinson's disease dementia, less common, but still we see frequently. Frontotemporal dementia, we tend to see less than 5% of cases in older individuals, 65 and above. But if you're looking at younger patients, age 40 to 60, frontotemporal dementia, that can be sometimes as high as 15 or 20% of cases. And then finally, we have to keep in mind that you can have a major neurocognitive disorder due to any type of medical impairment, whether it's a trauma, a toxin, an illness, or something like that. So we'll talk later about how we try to figure out those different types.
But specifically with Alzheimer's, which is, again, the most common form of neurodegenerative dementia, it is progressive. It's a cortical dementia, meaning the cortex, the thinking parts of the brain. It's often, I think many people believe it's caused by the buildup of two toxic proteins, beta amyloid and also hyperphosphorylated tau. These two proteins build up, get gunked up in the brain of a person with Alzheimer's, and a lot of attention from pharmaceutical companies and others have really striven to get rid of the amyloids, reduce it, attack tau, and these really the disease typically begins with short-term memory complaints, as we were taught in medical school, and it progresses over time, 8 to 12 years on average. But it will involve executive dysfunction, visual spatial complaints, personality changes, sleep changes. It's not just memory loss at all. And the existing treatments, there are several FDA-approved treatments that can help modify symptoms to some degree, but it does not help with disease modification. I think that's very important.
Absolutely. Now that we've defined it, it's really stunning to think about how prevalent Alzheimer's disease is. If you look at one analysis from the Global Burden of Disease study, this is data over 25 years, showing that Alzheimer's disease has increased from the 7th to the 4th most burdensome disease. And, this is based on looking at, how much loss are due to premature mortality. It's really stunning how that's increasing. In the United States now, roughly 5.8 million Americans are living with Alzheimer's disease. This number is projected to nearly triple by 2050. If you look across the world, 50 million people now have some form of dementia. This is projected to triple by 2050. And in part because we're seeing more of it, because Alzheimer's disease is a disease of aging and more people are living longer lifespans. Also because we're recognizing more and it's being coded more on death certificates. But you can see that the rates of death due to Alzheimer's disease in the US alone have increased by 145% since 2000. And the final data point here, which is really critical to emphasize, is that the cost to our economy every year is almost $300 billion. And this outpaces heart disease and cancer, which is stunning when you think about it. In fact, one of the main concerns is that we're just not doing enough research on it. And Richard, I know you know how much this translates into what goes on with caregivers.
Yeah. And, people say that Alzheimer's, is a devastating disease, and it is on the patient. But, patients with Alzheimer's, they're not just the patients affected, the entire family. And the burden on caregivers is something that we really need to pay attention to. Caregiver support is essential, in a management plan, and we'll talk more about that. But, there's just enormous financial costs, lost work days, increased rates of anxiety, insomnia, depression. And honestly, the average caregiver is an older person, usually the spouse, and they often have other medical comorbidities. So it's really important to recognize the dual impact of Alzheimer's on the patient, the caregiver, the primary caregiver, as well as also the entire family.
Without question. And one point we add is that for some caregivers, this is really difficult, really challenging. Others thrive on it. And it's interesting when we think about all the people they work with. For some people, it really gives them a sense of meaning. Let's take a look at a brief video to illustrate several of these points.
Honey, let's go to the bathroom. It's time to take a shower.
No, I took one yesterday.
Sharon, remember, yesterday you said you didn't want to take a shower. You said you would take one today.
That's not true. I didn't say that. I shower every day.
Sharon, it's been 5 days since the last time you took a shower. And we also need to change your clothes.
What are you saying? I change my clothes and shower every day. Why are you getting me mad?
Please.
No.
Sharon, honey, here are your pills.
Those are my pills? What are they for?
Well, one's for your high blood pressure, one's for your memory, and the other one's for your nerves.
Nerves? Why do I need a pill for my nerves and my memory is fine?
Sharon, remember, the doctor prescribed those pills.
I don't see a doctor. These aren't for me. Now stop it.
Sharon, please. Honey, take your pills.
No.
If we go back a little bit to just what causes this, what's the pathophysiology of this disease? How do you start with a normal brain and become a diseased brain? So lots of factors early on. Certainly we know genetic mutations play a role, depending whether it's early onset or late onset. We'll talk about that in a minute. Aging is the number one risk factor. Aging brings oxidative stress. If you look at what's going on inside cells and outside cells, you're seeing impaired protein synthesis. Cells that are older are less able to clear out damaged proteins. And the focus becomes on two particular misfolded proteins. One is a toxic form of amyloid protein called beta amyloid. The second is a form of tau protein. Now, the beta amyloid begins to precipitate out outside of neurons or extracellularly, whereas tau protein is a normal stabilizing protein in the microtubule system inside neurons, but it becomes hyperphosphorylated. It then becomes destabilized and forms these tangles, what we call neurofibrillary tangles, within neurons. This leads to damage and eventual collapse of the neurons. And this begins in earnest, the buildup of these two proteins, the pathological process that leads to the clinical symptoms we call Alzheimer's disease.
And, from various pathological studies over, long time ago, Brock and Brock, who are pathologists that really helped us understand this. We really understand now that through very early to mild to moderate, through the severe stages or phases of Alzheimer's disease dementia, the amyloid and the pathology spreads. So depending on where understanding neuroanatomy is something that I didn't love in medical school for sure, or residency, one of my least favorite subjects, even though they're very important. Understanding that the pathology spreads through different areas. Once, for example, the pathology hits the hippocampus, which is a memory center in the brain, well, then the memory symptoms will worsen. The temporal cortex, the parietal cortex, the parietal is visual spatial, for example. That's maybe when the person will start getting lost while driving. So it's interesting to understand that there's the location. Where is the location of the pathology? And then that really guides the clinical manifestation.
Yeah, it gives us a really good understanding of how the clinical picture then unfolds over time, just this wave of these toxic proteins and their effects moving through the brain. And so then we begin to see as the toxic proteins build up, you begin to damage the vasculature of the brain. You get even more oxidative damage on individual neurons and other components. As you get deposition of beta amyloid, you see an inflammatory response. The brain wants to get rid of it, and you have this confined space of the brain, so inflammation leads to damage and destruction of cells. If you look at inside the cell what's happening, you get a dysregulation of calcium metabolism, which is key to maintaining the integrity of the cell. We've recognized for a long time, you see insulin signaling dysfunction. The cells aren't able to take up glucose as much, so they're starved of energy, and you can get dysfunction of the mitochondria. And so as a result, what the cell does, transporting materials through its axons, the production and release of neurotransmitters and other neurotrophins, all these begin to fail. Cells begin to die. You lose cells. The metabolism fades. You see synapses are beginning to get more damaged and disappear. So you just get this inexorable progression of these losses within a cell. And the brain that once was a healthy, functioning brain becomes more atrophied, more dysfunctional, and you see these clinical symptoms.
Yeah. And as these clinical symptoms progress, we understand that there is a trajectory. And the trajectory starts with these cognitive symptoms, like we've talked about, and then slowly but steadily, people will lose their ability to function, or their loss of activities of daily living. Around this time, and honestly, even sometimes earlier, there can be behavioral trouble. Depression, it's a major risk factor for Alzheimer's disease, but depression is also a symptom related to Alzheimer's, so it's a little tricky to tease out sometimes. And then, unfortunately, as the disease progresses, it could be 3 to 5 years. It could be 5 to 7 years. And in some cases, Dr. Grona and I, we've shared patients that have gone, quite a bit longer, 10 to 12 years before requiring nursing home placement. And it's though progressive, it's a progressive disease. And if we can find something from a disease modifying way to intervene, it can really, pay dividends for the future.
And that's a good point when we talk about disease modification, because even a little bit of modification will really shape the course of this. Because it's so long and so slow moving. Let's talk a little bit about some of the risk factors. And there's some really good data out from, in particular, the National Institute of Health, also for the National Institute of Health and Care Excellence in the UK, looking at the main risk factors. So we know that in early life, genetics play a role. We also know that higher education can reduce your risk of later developing Alzheimer's disease. In midlife, individuals with hearing loss, with high blood pressure and obesity face an increased risk of Alzheimer's disease. In particular, I think it's been surprising seeing the impact of hearing loss. We don't fully understand how that plays into it. Is it because the brain is less stimulated, or there are other factors? But certainly is a potent risk factor. And in late life, some of the things you'd expect: smoking, physical inactivity, social isolation, diabetes in particular is a really potent risk factor. Also depression, in particular chronic untreated depression. But keep in mind that of all these different risk factors, only about 35% are potentially modifiable, or maybe I should say, guess what? 35% are potentially modifiable, because as Dr. Isaacson knows, who's really a pioneer in this area, Alzheimer's prevention can look at these different factors and really make a difference.
Yeah. If 1 out of 3 cases may be preventable, if that person does everything right, I'll take it.
That's a big deal.
It's not 100. It's, we're not at 75% by any means. But again, if we can intervene against modifiable risk factors, and then a disease modifying treatment comes and use everything together, that's when we can really make progress. So, there's a lot of complicated stuff about genetics and Alzheimer's disease. Just to try to keep it simple, the 3 most, common, which are very uncommon, but the 3 most likely early onset genes are presenilin 1, presenilin 2, and APP, or amyloid precursor protein gene mutation. These are dominantly inherited early onset. These are very, very rare. I can count on 2 hands almost how many patients I've seen with these genes, and these are usually people in their late 40s and 50s, honestly, not really in their 60s most times with Alzheimer's. But by far, late onset Alzheimer's is the most common form. It's ApoE4 is a variant that increases risk. 2 copies of that ApoE4 variant increases risk even more. But this concept of polygenic risk, it's not just about ApoE4. There are dozens of risk genes that I really believe are important factors, and that if we can figure out the pathologic aspects of why these genes push people down the road towards Alzheimer's, we can intervene a little better. And I think really genetics is the future of Alzheimer's, both prevention and treatment. And this is really the cornerstone of precision medicine and personalized health.
Yeah, I agree. No question about that. Because you look at all these factors, and there's so few that we really can intervene with now because we don't fully understand them. But the one I would pull out is ApoE4, because it's worth a little more discussion. And we know that this is, at least of all those different factors for later onset, this is a main genetic risk factor. The ApoE gene is located on chromosome 19. The main issue is if you have a copy of the E4 allele. So this will increase your risk and lower your age of onset. So if you have one copy, it increases your risk by twofold. If you're homozygous, it increases your risk almost fivefold. So it doesn't mean you're going to get it, but it certainly raises the possibility. We also know ApoE2 decreases your risk. ApoE3 is relatively neutral. We don't routinely test for this, in part because there's not always something you can do about it. Even if you know about this early in life, I think what we would say, and Richard, I'd love to have you jump in here, in terms of prevention. What do you do if someone does have ApoE4 or not? How does that impact what you'd want to recommend to them?
Yeah, so I think in clinical practice today, it's pretty uncommon for people to do genetic testing for ApoE. Our practice is very different. We see patients very early in the spectrum, and we're just learning more and more. For example, actually, we published a paper in the Journal of Prevention of Alzheimer's Disease about kind of just the evidence behind this. And I can tell you, it's definitely early, and we still have a little bit of a ways to go. But if someone does have an ApoE4 variant, things like exercise, things like smoking cessation, things like a Mediterranean style diet may be preferentially effective for risk reduction. Also, omega-3 fatty acids. If someone has a 4 or 2 4s even, the absorption of omega-3 fatty acids into the spinal fluid on a recent study is just so much lower. It's strikingly lower. So if we can increase omega-3 fatty acids through diet or supplements in some cases, early in the lifespan, even especially in people that have elevated cholesterol. So I think there are specific things that can be done, but I think we of course need more research, prospective longitudinal studies to truly understand the impact.
It's true. It's good to know at least that we're moving in the right direction of having something to do with that.
Yeah.
So we want to thank you for listening to this first module here. Please complete the post-activity questions, and also we'd love to have you join us for Module 2 of the series entitled Diagnosis of Early Alzheimer's Disease versus Mild Cognitive Impairment.